The quality of your prescription can never exceed the quality of your case taking. It sounds simple, right? But honestly, this is the absolute bedrock of clinical success. It literally means that your treatment, no matter how much brilliant theory you've crammed into your head, is only ever as good as the information you actually gather from the person sitting right across from you.
So, welcome to The Explainer. Today, we're taking the rigorous, slightly intimidating academic guidelines of Organon aphorisms 82 through 104, and we're transforming them into a highly practical clinical masterclass. Whether you're a fresh student or a seasoned pro, mastering these exact skills is basically what separates a mediocre clinician from a truly exceptional one. We've got a really clear path ahead of us today. We'll start with the art of case-taking, move on to mastering neutral interviewing, figure out how to map chronic disease timelines, pivot over to acute and epidemic cases, and finally wrap it all up with analysis and defensible outcomes. We are walking the exact conceptual path of a patient consultation from start to finish.
All right, let's dive into Part 1, the art of case-taking, focusing specifically on disciplined listening.
Which brings us right to Part 2, mastering neutral interviewing, and the really fascinating psychology behind it. To capture a case accurately, you absolutely have to act as a completely neutral observer. And this brilliantly illustrates the danger of putting words in a patient's mouth. Think about it. If you ask a leading question, something like, "Is your headache worse at 3 a.m.?" A lot of patients might just nod and agree with you just to be polite. And suddenly, boom, you're prescribing based on a symptom they don't even actually have. Now, compare that to a non-leading inquiry. What factors make your headache better or worse? It's open, it's totally safe, and it completely prevents your own biases from contaminating the facts.
Let's see how this plays out with a specific example. Say, a patient experiencing chronic stomach pain. It is so incredibly easy to accidentally ask these compound leading questions without even realizing it. Instead of suggesting, "Your pain is a burning sensation, correct?" which totally plants an idea in their head, we just rewrite it to a safe, neutral inquiry. "How would you describe the feeling in your stomach?" It's a subtle shift, but it's a total game changer. We must collect uncorrupted facts and authentic patient expressions, not just echo back our own assumptions.
Now, what's really interesting here is how structuring your consultation into these 5 deliberate phases guarantees you get a complete case, all without turning it into some kind of hostile interrogation. First, you prepare by building rapport and ensuring privacy. Then you invite their free narrative, and the trick here is not interrupting them to chase a hypothesis too early. Next, you clarify with those neutral questions we literally just practiced. After that, you complete the picture by gathering history and general observations. And finally, you close by summarizing their story right back to them just to ensure absolutely nothing was missed.
Okay, moving right along to Part 3, mapping chronic disease timelines, where we focus on reconstructing the patient's health story.
Reconstructing a chronic case really requires some deep, longitudinal detective work. You aren't just looking at a snapshot of today, right? You're essentially watching a movie of their life. The crucial point is that you must always map out their normal baseline state prior to the illness. Why? Well, that baseline allows you to measure exact deviations when the illness actually hits, and it gives you a solid metric for true recovery later on. From there, you just map out major life events, track how the symptoms sequenced over the weeks prior, and log their treatments, right up to the present day.
And a massive part of that timeline is the medication history. And it must be exact, whether we're talking prescribed meds, over-the-counter painkillers, or that giant shopping bag of daily supplements they brought in. You need to document the whole shebang. Note the dose, the duration, and exactly what improved or worsened after taking them. But, and this is a really critical safety note, never advise the abrupt cessation of essential medications. Your job here is to understand the pharmaceutical influences, not to instantly alter them.
Which leads us perfectly into Part 4, acute and epidemic cases, with a focus on focused triage and rapid assessment.
So what happens when the luxury of time just completely disappears? How must our careful, neutral, reconstructive methods adapt when a patient presents with a sudden, highly symptomatic emergency? Well, in an acute situation, that extensive chronic timeline we just talked about gets seriously compressed. The presenting complaint becomes the entire focus, and our immediate responsibility shifts 100% to safety and triage.
Seriously, before any detailed remedy questioning even begins, you have to clear these critical danger zones. You assess the airway, breathing, and circulation. You check for severe pain or altered consciousness. You are actively hunting for immediate red flags that require urgent medical care. Only when they are safe do you verify the acute cause,
And remember, don't let assumed causes obscure those potential red flags. Now, if that acute presentation is actually part of an epidemic, your strategy has to adapt yet again. You standardize your approach and collect comparable information from several complete cases to formulate what we call a collective totality. By doing this, you're able to separate the common, everyday symptoms that pretty much everyone gets from the truly unusual characteristic features that are uniquely shared across the specific outbreak. It's like putting together a giant puzzle.
Finally, we reach Part 5, Analysis and Defensible Outcomes. This is all about separating fact from inference.
So this is the synthesis phase. This is where we take all of that raw narrative, whether it's chronic or acute, and transform it into a characteristic, defensible outcome. To build that, you absolutely must strictly categorize your 4 information sources, because each one carries unique clinical risks. The patient gives you their subjective experience, but hey, human memory isn't perfect, they might have poor recall. A relative might provide a great chronological timeline, but they could also dominate the conversation with their own bias. You provide clinical observation, but you have to actively guard against your own observer bias. It's all about carefully separating verified, spontaneous facts from interpretations and assumptions.
Once you've got your reliable facts sorted out, you have to weigh their clinical value. Remember, a totality is carefully selected. It's not just copy-pasted straight from your raw notes. Spontaneous, repeated symptoms, those carry massive confidence. Strange, peculiar symptoms are absolutely fantastic, but only when they're genuine, so please don't force them. Meanwhile, common symptoms are helpful for a diagnosis, but they're honestly pretty terrible for individualization. You really want to weed out the redundant details and let those strong contradictions guide you, keeping the whole clinical picture sharp and coherent.
By finalizing your case synthesis through these 4 accountable steps, your reasoning becomes completely auditable. You start with a clinical assessment for safety. Then, you select the characteristic totality to individualize the case. Third, you justify your analysis. And finally, you establish a clear plan for accountability. This structured approach leaves you with a perfect, transparent baseline for when that patient returns for their follow-up appointment.
Excellent case-taking is accurate, it's individualized, and above all, it is safe. It requires you to listen freely, clarify neutrally, and analyze transparently. So, I want to leave you with this final thought. If the quality of your prescription truly mirrors the quality of your case-taking, what hidden assumptions are you accidentally bringing into your next consultation? Take a moment to really reflect on your own biases. Because becoming a master of the clinical interview isn't just about reading a textbook, it is a lifelong journey of learning how to truly listen.